Can you see the screen, please?
Yeah, we can see your screen. Yeah.
Good morning, greetings. I'm Aisha. I'm from the first semester, and I would like to present about pneumonia. Every 39 seconds, a child dies from pneumonia. So by the time I finish presenting, at least 30 children would have died from it. For a disease we know how to treat and prevent, this would never be the case. Today I will be going over the etiology, epidemiology, stages of pneumonia, a few signs and symptoms, clinical features of typical and atypical pneumonia, diagnosis and treatment. Pneumonia is a form of acute respiratory infection that affects the lungs. The lungs are made up of small sacs called alveoli, which fill with air when a healthy person breathes. When an individual has pneumonia, the alveoli are filled with pus and fluid. This makes breathing painful and limits oxygen intake. Let me break this down for you. On inhalation, oxygen starts entering the lung, where it crosses into the bloodstream via the capillaries for distribution around the body. Carbon dioxide, a waste product of cell metabolism, enters the lungs from the body in the bloodstream, crosses over into the lungs, where it is then exhaled into the atmosphere, moving out of the lungs. During a pneumonia infection, the alveoli of both or one lung fills up with pus or fluid. This increases the work of breathing and thus gaseous exchange cannot occur as it normally would. Speaking of etiology, pneumonia can be spread in a number of ways. The viruses and bacteria that are commonly found in a child's nose or throat can infect the lungs if they are inhaled. They may also spread via airborne droplets from a cough or sneeze. So in a global pandemic like this, social distancing helps us reduce the spread. Pneumonia may also spread through blood, especially during or shortly after birth. Research regarding different pathogens causing pneumonia and the ways they are transmitted is of critical importance for treatment and prevention. There are various causes of pneumonia. The modes of transmission is via bacteria. However, it can be passed from person to person and also from the environment. Bacterial pneumonia occurs when pneumonia-causing bacteria multiplies in the lungs. The alveoli becomes inflamed and pus is produced, which spreads around the lungs. And the bacteria could be Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, and all the listed. And in fungal pneumonia, though, it occurs in people who already have a weakened immune system or any underlying health issues. This is usually inhaled from the environment and does not spread from person to person. Mycobacterial pneumonia is mainly caused by a germ and inflames the lung, and this type of pneumonia is also listed as atypical pneumonia because the symptoms are different from those of pneumonia due to other common bacteria. Viral pneumonia is believed to cause half of all cases of pneumonia. The viruses invade the lungs and then multiply, causing inflammation. It has been reported that pandemic influenza A, H1N1, is also able to cause severe cases such as pneumonia, ARDS. Clinically, there may be a fever, dry cough, headache, sore throat, cold feeling, etc. Speaking of epidemiology, this is a common lung infection that affects millions of people worldwide. Worldwide infection rates are highest in developing nations, particularly in countries in Southeast Asia and Africa. When a patient has access to proper medical care, pneumonia is highly treatable and the prognosis for recovery is really good. However, in developing nations where the medical infrastructure may be suboptimal, sanitation is poor, the rates of poverty are high, pneumonia infection can be a serious medical condition, resulting in high rates of mortality. Children are particularly susceptible. This can. I'm sorry. If it's really raining bad here, I mean it's really heavily raining here. Excuse the background noise. Pneumonia infection can be a serious medical condition, and speaking of stages of pneumonia, pneumonia has 4 stages. When I'm if you're looking at the cases of LOBAR pneumonia and bronchopneumonia, it's namely consolidation, red hepatization, gray hepatization, and resolution. Consolidation stage occurs in the first 24 hours. It's the vascular engorgement and the small exudation of fluid and neutrophils in alveoli. The lungs start becoming baggy in a way. The exudates would contain neutrophils, lymphocytes, fibrins, and would eventually start replacing the alveolar air. This can be marked by coughing and deep breathing. In red hepatization, the red implies that the affected part of the lobe would start turning red, and the hepatization part would say that it would develop a consistency that would be similar to the liver, which is like a solid organ. This is due to the edema. This occurs in the 2 to 3 days after the consolidation phase. At this point, the lungs start becoming hyperemic, and this stage is characterized by the presence of erythrocytes, neutrophils, epithelial cells, and fibrin. In gray hepatization, the lobe starts turning gray. This is mainly because the RBC starts degenerating by this time. It still has the liver consistency though. It occurs 2 to 3 days after the red hepatization stage. And the pressure of the exudates in the alveoli would start causing compression of the capillaries. The leukocytes would start migrating into the congested alveoli. In the resolution phase, the edema starts resolving, the lungs starts being more aerated and returning to the normal consistency. The degenerated granular debris which would be present would be later exudated through the sputum. The presence of a few macrophages can also be noted. This is to clear up all the waste by phagocytosis and also would help in resolving the edema. This stage is characterized by reabsorption and restoration of the pulmonary architecture, so the lung will start coming back to its original shape. Signs and symptoms vary according to disease severity. Common symptoms would include fever, cough, sputum production. The color and the quality of the sputum provided would give an idea of the microbial etiology. So, pleuritic chest pain is mainly due to the localized inflammation of pleura. This can be seen with any kind of pneumonia, but it is more common with LOBAR pneumonia. And there are other constitutional symptoms like fatigue, headache, myalgia, arthalgia can also be seen. In severe pneumonia, this can lead to dyspnea and shortness of breath. In severe cases, confusion and sepsis as well. Tachypnea, increased vocal fremitus, agophony, dullness of percussion are the major clinical signs, which is also depending on the degree of consolidation and presence or absence of pleural effusion. If we look at the chest osculation, we could find crackles, rales, bronchial breath sounds, etc. In severe pneumonia, hypoxia can also be seen, which would eventually lead to hyperventilation. Now I'll be discussing a few clinical features of a general classification of typical pneumonia and atypical pneumonia. Atypical pneumonia is also known as walking pneumonia. It's any type of pneumonia that's not caused by the pathogens most commonly associated with the disease. Its clinical presentation would contrast to that of typical pneumonia, and a variety of organisms can cause it. Typical pneumonia would have features like a sudden onset of symptoms. This is caused by lobar infiltration. There will be severe malaise, high fever, chills, productive cough, purulent sputum, and the breath we discussed before, the decreased breath sounds, dullness on percussion, tachypnea and dyspnea. In atypical pneumonia, it has a slow onset and would provide a dry cough, dyspnea, but the osculation would often be unremarkable. The common extrapulmonary features would be fatigue, headaches, sore throats, myalgias, malaise, etc. There are several ways to diagnose pneumonia. The physical examination or osculation would show bronchial breath sounds or the fine cracks over the affected area. The pleural friction rub would be an adventitious breath sound that would also be heard during the osculation. This sound is mainly caused by the movement of the inflamed and the roughened pleural surfaces. The chest X-rays, though, often lag behind the clinical presentation. The chest X-ray would show decreased lung expansion and patchy opacity on the affected side with ill-defined margins. This is usually done to confirm the diagnosis, the sputum samples and the blood tests. These are done to diagnose the type of pneumonia that is present. Sputum test is done to determine whether it is fungal or bacterial pneumonia, or to examine the white blood cell count. This can also be used to indicate the severity of pneumonia as well as to determine whether it's a viral or bacterial infection. That is, if it was a bacterial infection, it would result in the blood count that has an increased amount of neutrophils. A blood count that has an increased amount of lymphocytes would increase a viral infection. Treatment will vary depending on how bad the symptoms are and what the cause of infection is. In viral pneumonia, this cannot be treated with antibiotics as they do not have any effect. This type of pneumonia normally resolves over time. Mycoplasma pneumonia is usually treated with antibiotics. Bacterial pneumonia, though, prior to the discovery of penicillin antibiotics, was a virtual death sentence. Today, antibiotics, especially given in the course of disease, are very effective against bacterial causes of pneumonia. Penicillin or other antibiotics are used. The treatment is really variable depending on if it's monotherapy or combination therapy, if it's community-acquired pneumonia, or if it's a hospital-acquired pneumonia. If it's community-acquired monotherapy is preferred, and amoxicillin or doxycycline or macrolide like azithromycin in areas of pneumococcal macrolide resistance is used. In case of resistant combination therapy, amoxicillin, claviculate, and amacrolide or doxycycline is used. In case of hospital-acquired pneumonia, check for risk factors of MRSA is done, and if so, one follows the antibiotics with MRSA activity. Doctors will also include the following when treating patients with pneumonia: breathing exercises, analgesic administration, cough suppressant medication, fever-reducing medication, oxygen therapy, that is when indicated. Chest physiotherapy is an agent commonly used in the treatment of pneumonia. However, there being little reliable evidence to suggest that physiotherapy has an effect on the rate of recovery of the patient. However, respiratory techniques are still commonly used to aid airway clearance and to improve the rate of breathing. Talking about the complications, pleural effusion is a really high possibility. That is when fluid accumulates between the pleura and the chest wall due to the large amount of fluid already present in the lungs. As a result of pneumonia, a pleural effusion may develop, which could lead to the collapse of the lungs if not treated appropriately. Empyema is when the pus may be present in the lungs due to the infection. Pockets of pus may develop in the cavity between the pleura and the chest wall, or in the lung itself, which is otherwise known as it. And we would have bacteremia. This occurs when the infection is no longer contained in the lungs and would start moving into the bloodstream, and thus the blood is infected. Septicemia would only occur if bacteremia occurs. It follows bacteremia, and this is an infection that can spread throughout the body. The infected blood is the best way for infection to manifest to other parts of the body. Another complication would be lung abscess. A lung abscess develops when the infection has destroyed lung tissue and the cavity is filled and pus is formed. And thank you, I hope, and that would be the end of my presentation today.
Thank you for the presentation, Aisha. We are here with another society today, the Infectious Society. It's a collaboration. So we'll take the comments on the presentation from the mentors, Ms. Publietse and Ms. Niedze. So Dr. Publietse first, I guess.
Thank you for the presentation. I have no comment. I'm radiologist. I can maybe comment on the next presentation, but thank you.
Okay, yeah. Dr.
Okay.
Niedze?
Yes, hello, thank you. Very, I think, nice, quite thorough presentation to remind us about basic things about pneumonia. And I think, well, everyone in time to time need to remind themselves about these basic things about pathogenesis stages and so on. But yeah, I also don't have a lot of comments. I think it was very well done, and thank you.
Thank you, Doctor. Thank you for the presentation, Aisha. We'll move on to the second presenter, Diana. Is she here? Yeah.
I will share my screen, so
yeah.
You see my screen now?
Yeah, we are able to see your screen.
You see the PowerPoint, or you see everything else?
Yeah, we can see everything else. Maybe you could try the presentation mode.
Yes. Wait, I will share only presentation. You see everything also now?
Yeah, now it's perfect.
Only PowerPoint, yeah. So yeah, it's quite a lot, so I will try to make it more. So, okay, let's see here. Do you guys hear me well? You hear me?
Yeah.
Okay, so let's speak about imaging of pneumonia, the radiology part. So basically, pneumonia summarized as a clinical syndrome, which is as a result of infection of the lung parenchyma leading to lower respiratory symptoms and typical changes on the chest imaging, which I will show later. And radiology is very important for diagnosis of a particular pneumonia. So for the distinction of the pneumonia, because there are various kinds. So the radiology, I cannot pronounce, the radiological classification can be different, but I choose the simplified version, where I will focus on the main types of patterns, which are lobar pneumonia, which can also be called airspace consolidation, non-segmental or focal non-segmental, but let's just call it lobar pneumonia. And then we have the lobular pneumonia, which could also be named as bronchopneumonia. And then the last one, we have interstitial pneumonia. And these are the main ones. So for the diagnosis, we heard the previous presenter speaking about the diagnosis, but here let's focus on the radiological findings. So, which is the gold standard for diagnosis of pneumonia, but there are various types of diagnostic tools. So basically, chest radiography is the main tool for diagnosis. So we have chest X-ray, we have chest CT, and we have the chest ultrasonography. In this presentation, I will basically only speak about X-ray and the CT. But these types of radiography are used in different situations, as you can see here. The X-ray is the first line investigation, which usually is for the confirmation of the infection, and this assesses the severity and complication of the particular pneumonia. And the CT is for the further assessment of complication, so after the X-ray is done. And this could also assess the causes of recurrent or non-resolving infection, so more complicated forms of pneumonia. And the ultrasonography is more for suspected parapneumonic effusion. So it's more outside of the lungs fluid. And then also it's used for identify septation with the fluid collection, and also for the thoracocentesis, which basically is directing needle placement for the pleural aspiration. So basically for removing the fluid between the pleura space. So let's speak about the basics of this of radiology X-ray, of the chest X-ray. So to understand what you can see in the X-ray or the CT, we have to understand that different kinds of medium have different kinds of attenuation, and basically attenuation means that the structure of the tissue can absorb, have a different absorption of the X-ray. So air or gas, they have minimal absorption. It means that the X-rays go through the tissue, causing a black image, because it's detected, the most of it is detected on the other side in the detector. And then we have the fat, which have a small attenuation, which means that it's slightly more grayish, but still dark. And then soft tissue, which have a medium attenuation, which means that it have a bow between gas and between the bone, so it has more grayish image. And then we have the bone, which is very rich in calcium, which have a high attenuation, which means that it absorbs most of the X-rays, causing a white image on the radiograph. So we have different kinds of film types. We have PA, which is posterior-anterior, which is the gold standard. And then we have the AP, which is anterior-posterior, which is less ideal. And then we have the lateral, which is not routinely performed, but still it's used. And the PA, it's the most commonly used, which is when the X-ray is from, which the X-ray source is from the posterior side of the patient, coming to is detected on the anterior side of the chest. So that's how it is. And then you can see the heart, it's smaller compared to the AP. And also the ribs are more downward compared to the AP, which is more horizontal. And also the clavicle, you can see it's more in the chest cavity. In the lung space, you can see going downwards compared to the AP. That's basically what you have to know. And then also we have the structures that is very important to know where they are located. So in this X-ray, chest X-ray, you can see that the lines are written or drawn to illustrate where the particular structure is located. The lung, as you can see, is have the biggest part of the chest X-ray, and the heart in the middle you see is more whitish, and underneath there's also a very big whitish area, which is the diaphragm. So yes, we can come back to this picture later if you have some questions, but I will just go through the chest X-rays here. Here's just a review. Also, we can go back later if there are some questions. We have lobar pneumonia, the airspace consolidation, also called, which is the microorganism damage to the alveoli, and this leads to the increase in the secretion of fluid into the alveoli of the lung, which spreads through the collateral drift, like the the surroundings of the alveoli, which involve entire segment of the lobe, which basically is the spreading of the fluid of the secretion. And then the consolidation of the lung is basically caused by fluid, cellular infiltration like macrophages, lymphocytes, and fibrinous exudates. Yes, and consolidation is a term commonly used for the X-ray. How to say, like, it's a term used for describing an area of the lung which is more whitish and more blurry. But I will show a picture of it so it's be more clear. And also lobar pneumonia is also characterized by relatively sharply marginated homogeneous consolidation, like clear whitish structure of the lung parenchyma, which is basically, parenchyma basically means the lung body, like the lung area. With patent airways, thus producing air bronchogram sign, and this air bronchogram sign means that the alveoli is filled with fluid, and the bronchus is very clearly seen as black. But I will show later what that air bronchogram really mean, this air sign. And these most common causes for this lobar pneumonia includes Streptococcus pneumonia, chlamydia, pneumophilia, Mycoplasma pneumonia, and also Klebsiella pneumonia. And this X-ray, like plain radiograph, shows in general homogeneous opacification in lobar pattern, and this opacification means that it's blurry. You cannot see through it, meaning it's not dark or like black, because because when it's black, it means that it's transparent. Yeah, and also segmental consolidation, which means that the consolidation area can be located in different area. It's not on one area, it can be scattered. And also it can also shown as non-opacified bronchus within a consolidated lobe that result in the appearance of air bronchograms. Yes, and I will show some examples here. Here is a picture illustrating lobar pneumonia due to Streptococcus in different patients. The first picture A, which is a chest radiograph, it shows the presence of consolidation. You can see it's the star, whitish area in this upper lobe. with this presence of air bronchogram, which you can see in the black arrow. It's not very clear. I think this picture is not the best one, but it shows that in this whitish area, you can still see the black, the bronchus, which bronchus is mainly not very clearly seen in general, like as a black. And then in the B picture, we have the CT, and this is the basically axial picture of the lung. And this picture you can see, this is basically a cross section. And this picture you can see consolidation. You see this huge whitish area as the star in this right lower lobe. In the picture you see it looks like it's left, but in the radiograph it's always will be the right. It's the opposite. So you see here in the star. And the next one we have the C picture, which also is a CT. Again with the lobar consolidation, you see the air bronchogram sign. You see that the very clear black or dark gray area. You see these lines. This is the air bronchogram where we have the surrounding of this whitish grayish area. And this is called the bronchogram sign, as you can see in this picture C in the lower area, gray whitish area with the clear black lines. Yes. And here's a case, clinical case with a female who is 30 years, feeling quite unwell. And in the frontal view, we have extensive consolidation and air bronchograms, as I spoke in the previous picture. We can see in the left lung that there is some black. Can you see my mouse? Yes or no? Here we can see a bronchogram. We have the black or darker gray area with the whitish surrounding. That basically means that the alveoli is filled with fluid and some pus. So there we can see it. And then we have also consolidation. Consolidation is very clearly seen in the right area of the lung, in the middle to lower lobe of the lung. In this picture looks like it's the left, but it's in the radiology, as I said, that would be the right. And also we can also see air-filled bronchi, as I spoke, the air bronchogram, and this is in this case is caused by pneumococcal pneumonia. Yes, that was that case. And the next clinical case, this is from a previous healthy 64-year-old man with fever and productive cough. And this picture you can see that the mass in the arrow, showing in the white arrow, white grayish area, which is called consolidation in the left upper lobe. Yes, and this is a continuation of the previous case, which shows the same picture, shows the same patient, but in the CT showing a consolidation, as you can see in the white arrow, pointing at this mass, whitish grayish mass, which is well marginated, meaning is that it's not scattered, it's on one location. And this abnormality resolved after antibiotic therapy, and the gram stains of sputum showed that it was caused by Streptococcus pneumonia. And the characteristic manifestation on the CT are lobar or sublobar consolidation, with clearly demarcated by the interlobular fissure. And this interlobular fissure is basically because the lung is divided in different lobes, and this fissure is basically the septa of between the lobes. Yes. And then we will speak about lobular pneumonia, which is also called bronchopneumonia, and this is caused by organism, like microorganism, which directly attack the peripheral airways, which damaging the wall of the terminal, like the last part of the bronchus and the respiratory bronchioles, which leads to necrosis of the walls, like the death of the walls, the bronchial walls, leading to a bronchiolitis, which is basically inflammation of the bronchus, and bronchitis, and the inflammation of the bronchus and the bronchioles, which is the smaller branch of the bronchus, leading to further secretion of fluid and inflammatory cells, and later involvement of the parenchyma, so of the other parts of the lung area. And this, in the radiographs, you can see patchy centrilobular or peribronchial nodules. Like nodules is basically a solid mass, which later on cause dense consolidation. So which will be seen as a blurry whitish grayish area. And the frequent causes of this phenomenon will be Staphylococcus aureus, Pseudomonas aeruginosa, and this also pattern could also involve Haemophilus influenza, Mycoplasma pneumonia, and Mycobacterium tuberculosis. And here we have an example caused by Pseudomonas aeruginosa. And in the first picture, chest X radiograph, you can see the presence of patchy opacities, which means that it's not solid masses. It's more very like, it looks little spooky and unclear, like masses, like not very clear defined, ill-defined. Centrilobular nodules, like meaning that it's located in the center part of the lobules. And also peribronchial thickening. So the bronchus is thickened. You can see in the white area, a white arrow, the thickening of the bronchus wall. And in the B picture, you can see a CT scan of the same patient with patchy peribronchial areas of consolidation. So in the bronchial area, you can see the patchy, like white grayish area, and also nodules, like solid masses, shown in as a small whitish around the nodule area, white arrow. As you can see in the white arrows are pointing at these nodules. Yes, here we have a clinical case of a 60-year-old man with a 3-day history of cough and feeling unwell. In the frontal view, you can see multiple small bilateral on 2 sides of the lung with areas of patchy confluent opacification. And opacification basically means that it's more whitish area. It's basically same as consolidation, like in the X-ray. But this confluent means it's not solid, it's not demarcated, it's more like kind of everywhere. And this lower zone predominant, it's very clear in the lower zone, so in the lower area of the lungs. And these findings are consistent with bilateral bronchopneumonia, usually it's seen. And this patient was also admitted to the for treatment with antibiotics and also with the respiratory support, so for the aid of breathing and under surveillance. Yes. Here we have the lateral view with the multiple small bilateral areas of patchy confluent opacification in the lower zone predominantly. And these findings are consistent with bilateral bronchopneumonia. This is the same things, it's just the lateral view. I don't have to talk about this picture, just in the lateral view showing. And here is after this 4 days of antibiotic treatment we can see almost near resolution of the multiple small bilateral areas. Almost the lungs looks clear. It's less whitish compared to what we've seen before. And the next one is, this is the interstitial pneumonia, which is caused by, as a secondary cause of an infectious agent, which damages the ciliated epithelial cells and the bronchial mucous gland cells due to edema, and lymphocytic cellular infiltration will occur. So basically, inflammatory cell will invade the bronchus and the lung area, and this will lead to alveolar infiltration and interstitial septal thickening. So the thickening of the bronchioles, and also in general, the lung will be more dense, more whitish. And in this type of pneumonia, we have more glass opacities. And this glass opacities means that it will look more light gray. It's similar to opacification, like it's similar to consolidation, these glass opacities, but it's more, usually it's more grayish, and it's more very, how do you say, it's gray, light gray, and it's more even in color compared to consolidation, which it can look more spooky and more little whitish, yeah, and indifferent in this gray scale, yeah, gray-white scale. And also this, we can see linear reticular, which is basically linear whitish, like how do you say, like it's more shown as lines, as a whitish line is how to say, it's shown as white lines basically throughout the lung area. And then we also have reticular nodular random nodules. It can be seen, and patchy consolidation. Basically, this interstitial pneumonia can have different imaging findings. It's just like it's a secondary cause of this infectious agent, which is more, it's more like an extended form of more like a progressed form of pneumonia caused by this virus that is not usually treated. And most common pathogens can be viral, basically virus, and we can also have bacteria like Mycoplasma pneumonia, chlamydia, which are the most common pathogens causing interstitial pneumonia, together with atypical pneumonias. But these are just usually called as basically these are called atypical pneumonias, which the previous colleague explained what that means. It's a little complex, this subject, because pneumonia is such a huge like topic, and in the radiograph you can see so many abnormalities. But I just want to go through different classification. But even when it's classified, it still can be a little too much. So yes, so here is an example in a patient with atypical pneumonia caused by this Mycoplasma. And in this radiograph, picture A, we can see the presence of bilateral reticulonodular opacities, shown as a white arrow. You can see this line, white is a line, but also it's seen as some nodule. It's like a between mix. It's a mixture of reticular and nodular. So it's yeah, it's quite unclear, but it's described as that one in the first picture. And in the next picture, it's the same patient, but with a CT, which shows ground glass opacities. And here you can see how it looks like. Ground glass, I think this is a quite bad picture, because in this picture you can see it's not very clear, these ground glass opacities. These arrows are pointing, but you can see it's more like even in color, and it's more located than as a solid area, but not always, but it's more whitish, like it's more like a solid light grayish area. And also ill-defined nodules, and these ill-defined nodules you can see in this white arrow, but yeah, white arrow, it's the one on the, you can see here on the right lung area, that's the nodule. And in the left lobe, in the left lung, you can see the arrowhead. It was a little confusing because here is arrowhead, which show the ground glass opacity, but again they look quite similar. But here again you can see with the arrow in the right side there is this small nodule. You can see it quite clear if you look very carefully, quite dark little mass with a white line around it, surrounding it. Looks like a nodule. Yes, was a little confusing here, but you can see here the ground glass opacity with the arrowhead in the left lung. Yes. Yeah, and nodular predominant pattern is another type of sign, which is a unique pattern secondary to hematogenous spread, which is basically the microorganism is spread through the blood. Spread of pathogen, or granulomata formation, which means basically granulomata formation basically means that the leukocytes, which includes lymphocytes, neutrophils, basophils, and all of these, and as solid mass. And these are most commonly found, these type of nodules are most commonly found as a secondary cause to septic embolization, like embolism, tuberculosis, or fungal infection, and rarely viral infection. And the random nodules are seen which do not respect any segmental boundaries or bronchovascular pattern. So it means that it doesn't always have to include, it doesn't always have to be very clear with how it looks like. It can be, it's not always very clear that this is a nodule. It can look in various pattern. And here we have an example of nodular pattern of pneumonia caused by miliary tuberculosis, which is a type of tuberculosis, which is more extensive form, which is spread, is more seen throughout the long parenchyma. And in picture A, you can see chest radiograph showing the presence of bilateral nodular opacity, which is basically opacity means that it's shown as whitish area. Yes, and the picture B, we have tiny random nodules. You can see these very tiny random nodules. It's seen as this arrow is pointing, you can see this very kind of light gray round area, like a solid mass. It's not very clear to see, but you have to look very careful. For me, it was quite hard to see it first, but it's diffuse, but it's there. Yes, and it's shown in the right lung on the chest X-ray. You can see the right lung. And here we have different types of pneumonia with different causes. And in the CT findings, you can see which correspond, which have the type of feature. For example, COVID-19 pneumonia, we have ground glass opacity. You see the first one, GGO, ground glass opacity is very common to find. And also we have crazy paving, which basically is like, how do you describe it? It's quite, it's like patches, like white patchy blackish. It's kind of uneven pattern of consolidation, basically. And it's also always, usually, not always, but usually located in the periphery of the lung and the lower zone, and it's usually rounded morphology, meaning that it's you can see it's common finding to see nodules or like round in a round pattern. Yes, I will go through it more in detail about COVID-19 pneumonia, and these typical findings are mostly peripheral bilateral ground glass opacity, which is common finding 40 to 83% of COVID-19 pneumonia patient. Right and left lower lobe are the most commonly involved. And as I said, consolidation, and also combined with ground glass opacities with consolidation. And these ground glass opacities are combined with interlobular or intralobular septal thickening, creating this crazy paving pattern. So it's like a combination of different kinds of pneumonia patterns, like radiological patterns, and also subpleural lineal opacities, which means that the opacities, like this whitish grayish area, is located in the outer areas of the lung. You see, I will show how it can look like if there will be picture. And as I said, air bronchograms can also be seen, vascular enlargement, like blood vessel enlargement, increase in size, and also CT halo signs, which basically mean like this black hole with white area located, like white line located, and also reverse halos. I will show that what that really means, but it's little strange terms. And also we can see cavitation, also pleural or pericardial effusion, and lymphoadenopathy, and these are rarely observed, but you can have them. So the CT findings of COVID pneumonia, we have, I think I have spoke about that, but the findings can vary. They can vary depending on the progression and the course of this COVID-19 pneumonia disease. In the early phase, it's predominantly unilateral, but it can also be bilateral with small peripheral ground glass opacities, and the size and the number of the ground glass opacities and the number of the affected lobe increase as the disease progresses, and this crazy paving pattern and consolidation, they can appear when the disease is getting worse. And the consolidation become denser, like meaning that it becomes whiter in the CT or in the X-ray at the peak stage, meaning that it's more like granuloma formation, so more like lymphocytes, leukocytes, and all these inflammatory cells. And after 2 weeks, usually the opacities start to resolve gradually, meaning that this opacities, like this consolidation with the granuloma, start to decrease and becomes more normal in the morphology. And also this residual, like the leftover, like the little areas of subpleural curvilinear lines, like along the lung parenchyma, and these fibrous stripes, and the ground glass opacities can also be seen. So yeah, it really depends from patient to patient. And here is the findings of a patient with pneumonia with COVID. The first picture shows the an illness on day 4 with a patient with pneumonia with COVID on day 4, which you can see ground glass opacities. You can see this patchy, not patchy, but gray, like light gray area in the right and also the left, but more in the right lobe. in the lower areas, as you can see. And on day 8, the number and the size of ground glass opacities increase. As you can see how it looks like. It looks more like a light grayish area, like it's more even in color. And in picture C, which is basically day 14, after 2 weeks, we can see the consolidation where dominant, you can see it's more patchy seen, whitish, like little uneven in color. And here's COVID-19 pneumonia patient with a CT section showing a segmental parenchymal consolidation with air bronchogram. Here you can see air bronchogram very clearly in the right lobe. You can see this dark lines, which is basically the bronchioles you can see, and the whitish areas you can see, it's the alveoli filled with fluid and pus, and it's basically an abnormalities when you can see these clear lines, the clear bronchioles. Yes. And here also nodular opacities with ground glass halo. As you can see, ground glass halo is very clearly seen here. You can see in the right area, we have the very, very whitish central part, and then we have the little more darker grayish area around it, which is basically what halo means. This is called ground glass halo. It's basically a ground glass pattern, but with a halo. It's with the whitish in the middle. And here we have reverse halo. As you can see here, reverse halo, we have the dark in the middle and light on the outer. This is called reverse halo appearance with a multifocal peripheral ground glass appearance. Multifocal, it means on multiple areas of the lung. We have also in the periphery, meaning it's more located in the outer part of the lung body parenchyma with ground glass opacities. Yeah, with the halo also we can see here. Yes, and here are the sources and the resources.
Thank you for the presentation. Any questions from the audience? I think there's one question from Rajika Rajeswaran. Is bronchopneumonia the same as lobular pneumonia? Maybe if you could show her the slide again. Yeah, I hope it answers her question. And yeah. Now we invite some comments from our mentors, Dr. Pavlietsa.
Sorry, the bronchopneumonia is the same as lobular. It's the exactly same, just a synonym.
Oh, okay, all right.
Yeah, therefore I made in brackets, because here is, as you can see here in the, I think it was this slide. Yes, you see the synonyms. It can be very confusing. There are many different terms, but I just, when I made this presentation, I wanted to make it more easy because there are different types of pneumonia patterns. So therefore I just made them, but also I spoke about interstitial. Yes, I also spoke about, what did I spoke about also? Yes, I spoke about nodular predominant pattern, which is basically also a different kind of pattern. But I just wanted to say that with this type of pattern, it's more unique. So I thought it would be quite interesting to know that it's also quite common, and yeah.
Okay, thank you for your presentation. I agree. The pneumonia is quite complex subject in radiology also, and as you said, you did very good presentation, very basic information which we all needed to be reminded of. But of course, we can do separate presentations for each of the subtype of pneumonia, and especially for interstitial pneumonia. It's very hard even for experienced radiologists sometimes to differ these interstitial types of changes. And what I wanted to say, just to test your alertness, I have a question. Why do we see bronchogram black? Just to test the alertness. Why the bronchogram is black, and yeah.
Because we have air in the bronchus still?
Yes, exactly. Very good. Just the alertness question, of course. And yeah, and about some few words about interstitial pneumonia. As you saw in X-ray, interstitial pneumonia can be very subtle, and in many cases, X-ray is normal in interstitial pneumonia, and yeah, it has very low sensitivity and specificity for interstitial pneumonia, and most likely we will use CT for the diagnosis. So yeah, and that's it from me. Thank you.
Thank you, Doctor. And now some comments from Dr. Sniedze.
Okay, thank you again for very, again, thorough presentation. And I guess me as just infectologist, I don't know a lot about radiology as such because the colleagues help us. But I had a reminder for me from the study years where we also looked at the X-rays and CTs, because now, the radiologist does all the work for us. But thank you for reminding these important things. Thank you.
Thank you, Doctor. And
one question about the diagnosis, because there was this table with all the different types of pneumonias and then the different signs on X-rays. And is it possible, I mean, to our mentor or the presenter, the question, is it possible to always distinguish the type, or can it be that it's so overlapping that it's not possible?
Most likely we will distinguish, for example, lobar pneumonia from interstitial pneumonia, but in case of interstitial pneumonia and all the other things that you showed in this table, as you said, the signs are sometimes overlapping, and we give differential diagnosis. If we don't know exactly what it is, then we do like a differential diagnosis at the end of our report. It's from the radiology part. Yeah, it's not that easy.
Thanks.
And any other questions? Okay, I don't think so. So yeah, thank you everyone for attending the meeting today, and a special thanks to our mentors and to the presenters as well. They presented wonderfully. This was our last meet for the semester, and yeah, see you all in the next one. Thank you everyone. Have a good evening.
Yes. Thank you.
Goodbye.
Thank you. Bye.